Hi, this is Elliot Fishman, and welcome to part 3 of our talk on renal tumors extending beyond RCC, pearls, pitfalls, and key diagnostic findings. And we left off last time briefly talking about renal oncocytomas, that they're relatively benign tumors. The biggest challenge is it's hard to diagnose an oncocytoma on a CT or an MR scan. Renal oncocytomas account for about 5% of resected primary adult epithelial renal neoplasms. They peak in the 6th to 7th decade with a male prediction, but these are the demographics that are pretty much the same as renal cell carcinoma. And again, it's difficult to distinguish, and that's why they're resected. Now, often they tend to be lesions that can have partial nephrectomies, so that's a good thing. They're often sharply marginated. They can have a sharp central stellate scar, which is classic for oncocytomas, but is seen in less than a third of cases, and occasionally scarring can be seen with other tumors as well. Remember, renal cell can have a central scar, so it's not going to be a perfect finding, but it can be helpful, often in retrospect. The only reliable feature is the fact that these lesions rarely will spread locally or metastasize, because these are really benign lesions. And again, the reason we pick up most oncocytomas, they're incidental findings. Now, sometimes patient will have abdominal pain or blood in the urine or an abdominal mass, but these are going to be infrequent. And in the NIH category, this is under the Rare Disease Information Center. The exact cause of most isolated renal oncocytomas is unknown. Multiple and bilateral oncocytomas can occur in certain syndromes like tuberous sclerosis or Birt-Hogg-Dubé syndrome. Although many benign tumors do not require treatment unless they are causing symptoms, again, the difficulty in distinguishing this from renal cell will make it very difficult, and it's only after the fact that typically you can make the diagnosis. So here's just a good example. You have masses in both kidneys. Some could be high-density renal cysts. Others are simply high-density lesions that are concerning. When you give IV contrast, particularly in the right kidney, you see multiple masses with a dominant greater than 5 centimeter mass centrally. You also can see additional lesions in the left kidney. So now we're talking about a patient with multiple vascular lesions. Now you can see multiple renal cell carcinomas. You can see occasionally multiple angiomyolipomas, and you can see multiple oncocytomas. These lesions do not have a central scar. They're solid. They're somewhat vascular. In addition, in the left kidney, but also the right, there are multiple simple cysts present. I think here I'm stuck. It looks like bilateral renal cell carcinomas to me with a dominant mass. Hard to manage the patient because of so many lesions. They might consider doing a right nephrectomy and then a partial on the left. That may be one way of doing it. But you can see the lesions wash out, very similar to papillary renal cell carcinomas. So I think you're stuck here. You have bilateral solid renal masses that are mildly vascular but not hypervascular. They do wash out, but they're solid. Most suspicious for multiple papillary RCCs, and that was the situation where there were multiple oncocytomas. Or this case, solid mass lower pole of right kidney. Is that a central scar? When you know it's an oncocytoma, you say it's a central scar, but I could show you many renal cell carcinomas where we talk about central necrosis. And so you can see the lesion very vascular. I still would have chosen a clear cell renal cell carcinoma, would have done a partial nephrectomy. You can see very nicely here on the 3D reconstructions as well. Here it is on the washout images. You can see the mass is well defined, sharply marginated. Yes, it has either central necrosis or that scar. Here it is nicely shown on the cinematic rendering. But I think at the end of the day, you're still going to dictate it, or I surely will, as suspicious for renal cell carcinoma, but the patient would be able to get a partial nephrectomy. And so that indeed was done, and this ended up being an oncocytoma. So again, this case, is that a central scar? Maybe it is, maybe it isn't, but boy, it sure looks like central necrosis, looks like a clear cell, and this is the challenge of oncocytomas. So again, something to think about, perhaps, but most oncocytomas are unilateral, and they're going to look very much like renal cell carcinoma. Here's another patient. Look at the upper pole of the left kidney, solid mass. Here you can see it looks identical to some of the cases I showed you earlier, not of clear cell, but of papillary renal cell carcinoma. Well-defined solid mass, vascular but not hypervascular. This looks like a papillary renal cell carcinoma. Upper pole, left kidney would be a great candidate for a partial nephrectomy, and that's what was done, and pathology said an oncocytoma. So again, you can see oncocytomas do occur, but I think in reality, it's not something you're going to diagnose in most cases prospectively. And again, this lesion to me is going to be a papillary renal cell carcinoma till proven otherwise. Very nicely, the 3D mapping again, which was used for preoperative planning for partial nephrectomy. And again, here it is again. Now, the question is, could texture mapping, perhaps with cinematic rendering, be helpful in distinguishing a clear cell or papillary from a oncocytoma? That's an interesting question, but I've seen no work in that arena to date. And again, I showed you a similar case before, but multiple solid masses, varying degrees of density and calcification, and the lesions are hypervascular. It looks essentially identical to the prior case, but multiple masses better seen perhaps in the left kidney, and these were all oncocytomas. So oncocytoma and particularly clear cell renal cell carcinoma and occasionally papillary when they're not vascular can look identical. And that's true across all phases from non-contrast through arterial, through venous, or delayed phase, as in this case, both on the axial and on the 3D mapping. So now we talked about, arterial phase or corticomedullary phase, however you want to call it. We spoke about the nephrographic phase at about 70 seconds. Now, the last phase is CT, what I would call CT urography or excretory phase. It's a critical phase. I think a lot of people did not get that phase routinely. They would look at the early phases and not bother. Well, excretory phase imaging is very important across a range of things. It's literally the best phase for picking up pyelonephritis. Remember, the striated nephrogram was described on IVPs, which were typically excretory phase imaging. Also, it's a critical phase for picking up processes that involve the calyces, including transitional cell carcinoma, including papillary necrosis, or other pathologies. The question always becomes, when you say CT urography or excretory phase, are you at 3 minutes, 4 minutes, 5 minutes, 8 minutes, 10 minutes? A lot of people will talk about 8 minutes. I don't like 8 minutes because the contrast in the calyces is too dense, and then you get beam hardening artifact and you miss a lot of the information, and you could miss small transitional cell carcinomas, for example, or overcall things because of beam hardening artifact. I typically like 4 minutes. Now, people say, well, 4 minutes, will the ureter get filled with contrast? We know from IVPs the answer is yes. And even at 10 minutes or 20 minutes, if the ureter is not obstructed, waiting longer doesn't really help because you have peristalsis, so the ureter will empty. So 4 minutes to me seems to be an ideal time for excretory phase imaging. I think it gives you a good combination of getting the calyces and pelvis opacified and yet allowing you to look at the calyces very carefully. Now, when you talk about excretory phase imaging, the lesion that is most important is transitional cell carcinoma. Patients with TCCs often present with hematuria. It accounts for about 10% of renal tumors, often multifocal, can involve the patient's kidney and ureter and bladder, either at presentation or later on. Age range is a little bit older than classic renal cell carcinoma. When you look at these TCCs or urothelial cancers, we talk about single or multiple sessile filling defects that compress the renal pelvis fat. We talk about pelvic-calyceal irregularities, which are like strictures. We talk about focal or diffuse mural thickening. We talk about calyceal amputation, and we talk about tumor-filled distended calyces. So our focus typically is on the renal pelvis or the calyces. I will say at times TCCs can be confusing. They can be infiltrating, can look like lymphoma or renal cell carcinoma, particularly when they're large. TCCs can give adenopathy, though they usually don't. They can involve the renal vein, though they usually don't. Large TCCs are the ones, when they infiltrate the entire kidney, that are most challenging, not so much to detect, but distinguish from a RCC or lymphoma or mets, or occasionally even an infectious process like XGP. Now, one of the things about looking at transitional cell carcinomas, on this early phase imaging, you don't see anything vascular, and the kidney is enhanced normally and symmetrically. If you look really hard, there's something going on in the right kidney, but is this normal or not? It's hard to tell because there are no perfusion changes right over there. If you go to excretory phase, now what you see is the renal pelvis and the calyces nearby are infiltrated. They're irregular. There's a soft tissue mass, and that soft tissue mass, I go backwards. Let me go back to here. This is where the tumor is. This is where the calyces are being destroyed, where the tumor extends to the pelvis, nicely shown on these images. TCC also shows better on the coronal views. Here very nicely you see the destruction of the pelvis and disruption of the upper pole calyces, which are irregular, consistent with an infiltrating tumor. And here it is on 3D. Now, one of the things about 3D, when I look at the calyces, if I'm looking at papillary necrosis, for example, or a stone or anything to involve the calyces of the renal pelvis, I do like MIP imaging. You can see here the MIP imaging shows a normal left kidney, but the right kidney upper pole, the calyces are distorted, they're irregular, they're infiltrated, and they're invaded. This is classic for a transitional cell carcinoma. Now, another case, you look at this patient with hematuria, see a big cyst left kidney, and is there something in the left kidney here, or maybe that's just normal kidney? Hard to be convinced. Now you go and you give IV contrast. There's good cortical medullary differentiation bilaterally, but is there something going on in the patient's left kidney right here? Now, you're not really sure, so one of the reasons we get later phase imaging, particularly excretory phase imaging, is to really look at the calyces. So here, this area which measures about 64 Hounsfield units has to be concerning. Here it is again on the coronal view. What's kind of going on in the kidney? Is there something going on here to the upper pole, or is there nothing going on there? Is it just simply lack of filling? But it's challenging on the early phase imaging. But now when you go to excretory phase, look at the deformity of the pelvis and the calyces. There's a little bit of contrast here. You see a lack of contrast for the most part, except for this little area here in the mid to upper pole calyces to the upper pole of the left kidney. And then when you take those coronal views and you put it with MIP 3D, look how the calyces to the upper pole are distorted. Now you can see on the right kidney, you don't see the upper pole, and often unless you have good distension, you may not see the upper pole calyces perhaps, but you don't see the irregularity and the distortion that we see in this patient. And this is a classic transitional cell carcinoma infiltrating the patient's upper pole calyces and renal pelvis. And you can see in this example, again, another one where some faint calcification, which always worry me. The pelvis looks thickened, kind of like the last case. And as you give contrast, you can see a little bit of enhancement in the pelvis, those linear densities centrally. As you go to the cortical medullary phase, There's an infiltrating process in the renal pelvis here, faint calcification, something is going on here. And then as you go to the excretory phase, you could see that the patient's left ureter and right ureter look good, but you look at the calyces are blunted and dilated to the upper pole, but there's this distortion of the pelvis and the calyces here. Here's normal renal pelvis. Here's this infiltration and irregularity. That's going to be a transitional cell carcinoma. You can see how much easier it is to see on the excretory phase, particularly on the MIP imaging. Here's the distortion of the calyces on the cinematic rendering, very nicely shown in this example. Another case. Now, one of the things we try to tell people is if you only have one phase and it's early phase, look at the kidneys. You look for mass, obviously, but also look at the renal pelvis. In this case, the renal pelvis on the left is a bit fuller than the right, but on the right, you can see the pelvis is water density, which it's supposed to be, right? That's urine. But on the left, it looks like soft tissue. When you see that appearance, that's a transitional cell carcinoma. It's very easy to walk by because you don't see hydronephrosis and you don't have late phase imaging. Here it is on the coronal view. You can see that there's the pelvis normal on the right. There's the pelvis and proximal ureter on the left normal. But look at the mid to lower pole of the left kidney. In the calyces, there's a soft tissue mass. Now, one can argue, could this be hemorrhage? The answer is, I guess theoretically, yes. But if it's hemorrhage, probably something bled, and I would have to worry about a mass bleeding. I don't see an opaque stone. And here it is on excretory phase. Now you see the mass very nicely. You see the distortion. It's a small mass, under 2 centimeters, but very clearly seen, really nicely shown again on those MIP images. Look at the distortion of the calyx, the interruption irregularity of the renal pelvis. Just a really, really nice example. Again, the importance of looking at the MIP imaging of the kidneys on the excretory phase imaging. The contralateral right kidney looks good, but the left is obviously infiltrated. Now, to be fair, I will admit at times, if I only look at the MIP imaging, I might overcall the presence of disease. Sometimes it just doesn't distend out well. So there is a challenge at times, but in most cases, it's going to help you make the correct diagnosis. Now, we talk about TCCs being smaller, but they can be larger and more invasive. Here you see an infiltrating tumor in the upper half of the patient's left kidney on early phase imaging. And then you notice there's involvement and dilatation of the left renal vein. Here's the renal artery. There's the tumor in the left kidney, nicely shown here as well. Now this tumor is bulkier. Maybe it's a papillary renal cell carcinoma that's infiltrative. That's a thought, and papillary and clear cell are more likely than TCC to give you renal vein invasion. But in this case, you can see the tumor infiltrates the upper pole of the left kidney. It's large, and then as you come down, it grows toward the renal pelvis. And as you go to excretory phase imaging, you can see the pelvis and the upper pole calyces are non-visualized. They're distorted, they're eroded, they're infiltrated. Could this be a TCC? Yes. Could it be a renal cell? Potentially, yes, because it's a big bulky mass present. But when you see the calyces being distorted like this, particularly the early phase, but also in this phase, you got to think about the possibility of transitional cell carcinoma. Now remember, a TCC, you can't do a partial nephrectomy. You need to do a nephrectomy, remove the ureter, and remove part of the bladder because those tumors will commonly seed, and in 40% of the time you'll get a second site of disease. So it's important to think about a TCC, but you need to be very careful. And here's some MIP imaging later on where the lower pole calyces on the left are not well seen, but they're there, but the upper pole is gone and distorted, and that's the patient's transitional cell carcinoma. Another example, infiltrating tumor right kidney. Looks like it involves the renal pelvis. Here on coronal view, it does involve the renal pelvis and the upper pole. It's infiltrating. Can it be a papillary RCC? It could be. Could it be a TCC? Yes, it could be. You do see some adenopathy here. We see adenopathy more common with renal cell, but this case I show to make the point that you can see transitional cell give adenopathy. I showed you transitional cell being large. I showed you TCC invading the renal vein. So TCCs can be aggressive, but again, this appearance of infiltration on the venous phase imaging, and then the lack of opacification of the calyces, the mid and upper pole on the excretory phase imaging, pushes you to the diagnosis of transitional cell carcinoma. Here it is very nicely shown on the patient's cinematic rendering. Now, I want to speak a little bit more about transitional cell carcinomas and some of the challenges in diagnosis. So let's do this. I'm looking at my clock. We're kind of past the 20-minute mark for the third session. Let's stop here and come back in a few minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.